Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is determinants of first-line ART regimen and CLHIV. We'll be discussing the case scenarios today. We have with us Dr. Rohini Gupta. Dr. Rohini Gupta, ma'am, is a pediatrician with an MBBS and MD from Armed Forces Medical College, Pune. She has completed professional development courses from the University of Washington in leadership and management in health, implementation science, and clinical management of HIV. With over 35 years of extensive healthcare experience, she has served in Army Medical Services, led public health initiatives, and offered technical support for mentoring ART centers. Since 2009, she has supported NACO in developing national guidelines, NACP training content for CST cadres and STI RTI medical officers, and treatment literacy materials. Her key contributions include formulating guidelines for HIV treatment, preventing mother to child transmission of HIV and syphilis, and strengthening HIV counseling and testing services. She is also a member of NACO's Technical Resource Group for Pediatric ART. We welcome you, ma'am, for today's session and request you to start the session with pre-test.
Thank you, Shweta. You will be showing the pre-test, the
Yes, ma'am.
pre-poll, right?
Yes, ma'am.
So I'll just mute myself till we finish the pre-test.
Yeah. Requesting all the participants to please attempt the pre-test poll. The questions are visible on your screen. There are 4 questions in all. Please scroll through the questions and click on the answer of your choice. We'll give 5 minutes for the pre-test. Requesting all the participants to please attempt the pre-test. This is an anonymous poll. Your names or the ART center names will not be displayed or anything. Requesting all the participants to please attempt the pretest. There are 4 questions in all. Scroll through the questions and click on the answer of your choice. We have another 2 minutes left for the pretest. We'll end the pretest now. Over to you, ma'am.
So, good afternoon, everyone. Uh, Let's start with the presentation. My request to all of you is that you please uh, ask questions whenever you have any doubts. Please clear all your doubts about pediatric ART regimens, first line pediatric ART regimens in this NDLS. So, would like to have a very interactive session where you'll answer all. There are quite a few prescription writing questions and also case scenarios. So would like you all to participate in all the questions. So just to have, I'll be switching off my video so that the presentation doesn't get too heavy for the internet. So I would just like to discuss and help you all understand what are the national guidelines on ART initiation in children living with HIV, which I'll be which I'll be speaking as CLHIV. So one is the goals of ART in CLHIV. How are they different from adults? What is the evaluation of a CLHIV before ART initiation? I'll just be highlighting what is different for children before ART initiation. What are the first line ART regimens in CLHIV, especially with the DTG 10 milligram dispersible tablets, which are now available? And what is the ART regimen which is to be given in TB HIV co-infected children now that DTG 10 milligram is available? So all the ART regimens have kind of changed since the induction of DTG 10 milligram dispersible tablets. So the goals of ART remain the same in children, except this goal where we also uh, have one goal of promoting optimal growth and development of this child living with HIV. And therefore, the assessment, a baseline assessment of the growth parameters, the developmental assessment is very important. Only then can we monitor what is the development in the growth parameters and the development milestones. So the first step in preparing a child for ART would be to identify a caregiver. Usually parents could be a family member if the child is an orphan. But always remember, if parents are caregivers, then they would also be HIV, have HIV infection and would keep falling ill. So we, in children, usually advise a backup second caregiver, which would know what is the drug to be given, how to be given, what is the dosage of the ART, which is to be given to the child. The second step in preparing is an initial assessment of the child. We need to have a baseline clinical and lab assessment. We need to also assess the child for signs of seriously ill child. We need to screen the child for advanced HIV disease. We need to evaluate and diagnose and management or opportunistic infections, especially tuberculosis. We need to also do a baseline psychosocial assessment of the caregiver and the child. Initiation of cotrimoxazole preventive therapy is very important in children. All children less than 5 years of age have to be initiated on CPT. Preparing the child and caregiver for lifelong ART is one of the most fundamental steps which need to be completed in satisfaction before we start ART. And preparing the child is different, and preparing the caregiver and the secondary backup caregiver is as important. In children, we need to stabilize the child before ART initiation. We need to, that is why these two things are there. Assess for seriously ill child and advanced HIV disease. If any of these are present, then the child needs to be evaluated and stabilized if there is any infections like pneumonias, diarrheas. We usually in children wait and stabilize the child before we start ART. So rapid ART is there in children. I'll tell you about the indications, but we need to stabilize the child before we start on ART. So let's look at the first case scenario. And I would like to have a look at the chat box so that you can give me in short, what would be the answer? So we have Miss A, a newly diagnosed HIV child with HIV who's 2 years of age. She has persistent oral thrush. She has achieved normal developmental milestones, but has failed to gain weight and height. So weight is 6 kgs for 2 years is less than -3 Z score, and height is 72 centimeters, which is less than -3 Z scores. These you will come to know once you plot it on a growth chart. So the growth charts are available in our national guidelines in the annexures, and it would be really good if you could start monitoring your children's growth parameters by putting down the baseline, marking the baseline for the height and weight growth charts for the child before ART initiation as the first entry. And thereafter, you can see whether the child is gaining weight and height according to uh, the scores. Has the weight and height improved after ART can be noted on seeing plotting on a growth chart. CD4 was 18% and HP was 7 grams per deciliter. So what needs to be done before ART initiation? What is the clinical stage of the child, and is CPT indicated in this child? So can someone just put a few things in the chat box? I'll just wait for a minute to see any answers, and then I'll go to the next slide. So let's do the first answer to the first question. So what is to be done? We need to do a head-to-toe physical examination. Very important in children. Children will never tell you that I've got a rash here, or I've got itching in my scalp or in my neck. So you have to do a head-to-toe physical examination, including the oral cavity, the skin. You need to remove the clothes in presence of the caregiver and do a detailed examination. The growth assessment, as I said, a baseline parameters need to be plotted. Development assessment, we need to find out what are the baseline development milestones that the child has achieved at the start of ART. Screen for signs of serious illness and advanced HIV disease, which is very important. Baseline investigations include CD4 count and the other baseline investigations which are there in our national guidelines. Screening and management of OIs, including 4S screening for TB. The 4S screening for TB is a little different in children. Preparedness counseling after identification of the caregiver. CPT initiated, and you need to check for its adherence in the initial few visits, because the ART drugs are also going to be given, the CPT is also to be given. So actually the preparedness counseling should be exact timing of all the drugs which are to be advised. And last not the least is the management of severe malnutrition is essential, and usually you need hospitalization to manage this. Now, what are the clinical assessment? As I said, head-to-toe examination. So you must look for wasting, you look for oral thrush, you look for edema, you look for any difficulty. You ask the mother, is there any difficulty in swallowing, fever, anemia? These are all signs of nutritional state, any signs of muscle wasting, any signs of vitamin deficiency. These are very important, and you'll only come to know if you're going to be examining the eye, the oral cavity, and the skin. The find features of OI, find any signs of pneumonia, dehydration. These are very important in children. So what is the definition? Just to recap the definition of advanced HIV disease in adults and adolescents above and children more than 5 years of age, it is CD4 less than 200 or WHO clinical stage 3 or 4. It includes those who are not studied in ART and also those who return after being lost to follow-up. But all children less than 5 years who have not been initiated on ART are considered as having advanced HIV disease. So hence you need to screen for HIV disease, advanced HIV disease, and especially in all children less than 5 years. So what is this? What is the role of medical officers in screening for children living with HIV less than 5 years of age? So this is a flow chart which is given in our guidelines. So first you do a 4S screening. What are the 4 symptom signs where you need current cough, fever, poor weight gain. Now, poor weight gain can be no weight gain or weight loss. Both are included. These symptoms are included in poor weight gain. And the fourth symptom, 4S symptomology is history of contact with a case of TB. Now, if the child has any of these, then we need to investigate for TB. And if there is sputum, then you can do a sputum test or you can do a gastric lavage. TB lamb is not available, so this thing is not available at present. But we can do a clinical examination head to toe to find out any signs of extrapulmonary TB in the child, like a lymph node or any chest signs or hepatosplenomegaly, and do appropriate investigations. For TB, I'll be speaking about evaluation of TB in children in the next few slides. The next thing is look for any danger signs. So what are the danger signs you see? You find out whether the child, so you ask about not able to drink or breastfeed, ask mother or caregiver about vomiting repeatedly, convulsions or fits, lethargy or unconsciousness, and stridor or noisy breathing in a calm child. And you should look for fast breathing, chest in drawing, sunken eyes, uh, signs of dehydration where the skin pinch retracts very slowly. There is fever, and there are signs of meningeal signs like stiff neck and bulging anterior fontanelle, or the other signs of meningitis. Also, what needs to be added here is an SpO2. Now, since COVID, all our ART centers usually have a SpO2 uh, uh, this thing machine. So you can also note down what is the SpO2, and any SpO2 less than 90% indicates that there is the child is having some danger signs. It's one of the danger signs. Now, if there are no danger signs, then we go on to the next thing is severe acute malnutrition screening. But if any of the danger, even one of the danger signs are present, then we need to send this child for management to the emergency and hospitalization. If the center doesn't have a hospitalization or a pediatrician, then you need to send to the nearest referral center where a pediatrician is available. If there are no danger signs, then the next assessment is for acute malnutrition. And these are all the signs which are given here. If there are any of these, then this child needs to be admitted. The next is that you need to look for other signs of OIS. So what are the signs? If any of the danger signs are there, or any sign of subacute malnutrition is there, or WHO clinical stage 3 or 4, or CD4 less than 200, or signs of opportunistic infections like pneumonia, diarrhea, uh, or 4S symptom positive, then this child needs to be evaluated for advanced disease management. And look at this left. This box is actually what a medical officer needs to see in a synopsis. So you assess for danger signs and serious illness presence. You screen for signs of severe acute malnutrition, screen for and treat OIs like tuberculosis and meningitis. And if there's meningitis, we delay the onset of ART by 4 weeks. If there's tuberculosis, we first start TB treatment, and then within 2 weeks, we need to start ART. I'll speak about these two later. Rapid CPT initiation and TPT if there's no signs of active TB, rapid ART initiations, and intensive counseling and follow-up. So this should be actually taken out and kept as a printout. Evaluation of TB in CLHIV, we got a lot of queries from the field that they are finding it difficult because they don't have a pediatrician in their center for evaluation for TB. So I would like you to share the TB pediatric treatment guidelines 2022, which are not only for pediatricians, it's also for medical officers working in the field. And this is the chart for HIV. It's given. So if you see, there is a chapter 7, which is management of TB with HIV co-infection. There are these things are all covered. So if you ever have a doubt or anything, please refer to this guideline. The link has been given from where you can download this guideline. And this is the flow chart, which is the diagnostic algorithm for TB and CLHIV. So the first thing is you do 4S screening. Once, even if one of the signs in 4S screening are positive, it becomes a presumptive TB case. Now, presumptive TB case has to be divided by the medical officer, whether it's presumptive pulmonary TB or presumptive extrapulmonary TB. If it is presumptive pulmonary TB, then it's best to try and find out a sputum, if the child can bring out a sputum, or a gastric lavage, uh, and an X-ray chest. And according to these results, you will diagnose whether it is bacteriologically positive TB or clinically diagnosed TB, or it's not TB. And then you have to go ahead if the child is still symptomatic with cough or something, and then you would need to go ahead and treat for chest infection and follow up by a pediatrician. And if the pediatrician opinion says that yes, you can start ART, you may as well start ART. But this means that no signs of TB have been this thing, and no signs of pneumonia also there, because the X-ray chest is negative. So we can start on ART in this child. The presumptive extrapulmonary TB, you need to examine which pulmonary extrapulmonary TB you are planning to you're going to investigate, depending on what are the signs are there. So this is a very nice flow chart which can be utilized by medical officers to diagnose TB. Now, if you have certain specific TB which you are suspecting, then these flow charts. This is available. It's called Standard Treatment Workflows for India 2022 special edition on pediatric and extrapulmonary tuberculosis, and it's available at this website. And the things covered in this is pediatric abdominal tuberculosis, pediatric intrathoracic tuberculosis, pediatric lymph node TB, pediatric or bone TB, and tubercular meningitis. So the flow charts are something similar. I've just given a screenshot of this TB lymph node, when to suspect, what are the symptoms you need to look at it, what essential investigations can be done, what desirable investigations to be done. And this is the flow chart. If you have a peripheral lymph node more than 2 centimeters, this is pertaining to children itself. Okay, so I'll not go in detail because I've been told there'll be a separate session on this, but you can also download this and refer to it as a resource whenever you are at a when you face problems in diagnosing TB in a child. So ideally, all children should be seen by a pediatrician and comprehensively assessed. All newly diagnosed should have a baseline examination by a pediatrician, but sometimes pediatricians are not available. But there are certain situations which require a pediatric referral, and that is malnutrition, poor weight gain or growth failure. There's delayed developmental milestones. There is loss of previously attained milestones, or there is some associated systemic disease like a nephritis, or the child has some history of jaundice in the past, or has some raised LFT parameters which need to be evaluated, a seriously ill child, and the presence of a systemic opportunistic infections. These kind of children need to be seen by the pediatrician. So now if we go back to the old thing, what was the clinical stage of this child? Are there any answers? What was this clinical stage of this child? If you remember, it was the height and weight was less than -3 Z score. So the child had severe malnutrition and should be evaluated by a pediatrician. CPT is indicated. Yes, CPT is indicated as a child is less than 5 years, and irrespective of the clinical stage, the child should be put on syrup or trimoxazole 5 ml once a day. Rapid ART initiation in children. So rapid ART initiation means within 7 days of getting HIV diagnosis, the person should be started on ART. But the same thing is for children after appropriate preparedness. However, in children, ART is not an It is not an emergency intervention. You need to treat, manage all the OIs. You need to give a proper treatment preparedness with a caregiver, explain to the caregiver, because if the child is going to be cared by a caregiver and the caregiver forgets to give the medicine, then there's no idea of starting ART in a big hurry. And seriously ill and hospitalized children should be stabilized and ideally started ART before they get discharged. So as in adults, 3 drug regimens are given in the ART. So the first drug is always going to be abacavir, which is a preferred first line NRTI for in children. The second NRTI is lamivudine, which is a component in adults also and in children also. The third drug varies according to the weight of the child. So if the child is less than 20 kgs, it will be initiated on DTG 10 milligram dispersible based tablet. So the third drug is going to be DTG 10 milligrams. Now, the previous guidelines had an age and weight criteria. Now the new guidelines, since DTG 10 has come, it is weight based. So CLHIV, all children, irrespective of the age, less than 20 kgs will be put, the third drug will be DTG 10 milligram. For children more than 20 kgs, but the third drug will be DTG 50 milligrams. Okay. Now, in all children who are more than 10 years and weight is more than 30 kgs, instead of abacavir, we would be giving tenofovir to align it to the adult regimen. Okay. So these are the few pointers which we need to understand. So I'll just recap. The first is abacavir as the NRTI preferred. Second drug in the ART regimen is lamivudine. All children less than 20 kgs would have the third drug as DTG-10. All children more than 20 kgs would have DTG-50. And all children more than 10 years and more than 30 kgs. So both criteria where we can give tenofovir, then we would be giving these children the adult TLD. So just to explain further, so these are the three. This is the flow chart, which these are the ART regimens which come out. So all children less than 20 kgs would be given a abacavir lamivudine as per weight band twice a day and a pediatric DTG 10 milligram as per weight band once a day. If the weight is between 20 to 30 kgs, we would be giving abacavir lamivudine FDC twice a day as per weight band and 1 tablet of DTG 50 milligram once a day. If the weight is more than 30 kgs and age and both criteria need to be fulfilled, then the child will be put on the adult regimen of TLD, 1 tablet once a day. The two things we need to remember is that if one of these criteria is not present, then we would be go back to ALD in this regimen. So only if both the child is more than 30 kgs and more than 10 years, would we be starting the child on TLD. We need to calculate the dose of AL, FTC, abacavir, lamivudine 60-30 and DTG 10 milligram according to the pediatric dosage chart, which I have put up over here. And everyone can take a printout of this from the national guidelines. It's given as an annexure to. So what are the advantages of 10 milligram DTG? It is a simplified dosing schedule. You have dispersible tablets vis-a-vis the syrup lopinavir or the tablet lopinavir pediatric tablet, which used to be bitter. That is once a day. The DTG is once a day, 10 milligram. It's easy to administer. It's got a better taste. It has a strawberry flavored taste. It has better tolerance, lesser side effects. It's got a faster viral suppression. It has a high genetic barrier for resistance. And in various studies, they have found it to be superior compared to the ritonavir boosted lopinavir, which we used to use in children less than 20 kgs. And it harmonizes. So if the child is more than 10 years and 30 kgs, the child can continue lifelong TLD. So what are the counseling messages? Just in short, one is you need a lifelong ART and importance of adherence and viral suppression need to be told to the caregiver. We need to explain the benefits of this new medicine, which has come DTG 10 milligrams. we can explain about very few side effects vis-a-vis the other side effects which may be there. Explain the various steps to take. I'll explain these 10 steps in a video form later on. Specify which you can use as a tool to counsel and teach the parents and the caregivers how to give DTG-10. We need to explain the dose uh, to the parents that it will change as the child gains weight. So they should each time insist that the child's weight is taken and understand that now what is the dose, and fix the timing of giving all the medicines. So DTG also has interaction with various drugs like antacids, laxates, oral iron supplements, calcium supplements. So the DTG should be taken 2 hours before or 6 hours after, especially if the child is also taking hematinics and calcium and other vitamin supplementations. So what are the things? Explain what is to be taken. Explain that DTG 10 milligram is a dispersible sport tablet and its dose should be understood. Explain that after giving the dose of DTG, the child should be observed for about half an hour. Even after giving the dose of abacavir lamivudine, any of the ART drugs, the child should be observed for half an hour. So it shouldn't happen that you give the ART drugs and the child goes to school. The child has to be observed for half an hour. If the child vomits within half an hour of taking the ART drugs, the dose has to be given again. So the timing of the dose should be at least half an hour to 40 minutes before the child leaves home. And the child should not be sent off to play immediately after taking the ART drugs. The when is to be taken? DTG is very this thing. It can be taken anytime, fixed as per the convenience of the child. It can be taken with food or without food. It can be taken with water also. So there is no specification about how it has to be taken, but it should be ensured that the timing of the drug, which is to be taken once a day, is fixed according to the routine of the child. And this timing, if the parent should be explained that, okay, now we are taking this, but if the child's school timings change, please come and tell us, then we will reassess and see if we need to change the timing of the DTG. Do not change the timing of the ART drugs as per their own understanding. So this much rapport should be built with the parents and the caregivers, that in just in case if the routine of the child is changed, either the child is now going to some tuition classes or something and there's a difficulty, instead of they taking a decision on changing the timing of the ART drugs, they should come back to the ART staff, the medical officer, the counselor, the staff nurse. They all should discuss this and then fix the timing of the ART drugs. Identify who's going to give. So the primary caregiver, usually mother, or a secondary grandparents if or a guardian if the child is an orphan, and essential to identify a backup secondary caregiver. This is very important. We've had children who stopped taking medicine because the caregiver was not present. One of the important things is a pre-ART activity, which we used to follow in our pediatric center of excellence, where we used to teach the child pill swallowing. So there were so many children who were 5 years and above who had never swallowed a pill. So we used to ask the parents to get peppermint tablets and teach them how to swallow. And about dispersing tablets, how to make the DTG, they can be shown the video, and maybe the first dose can be given in the ART clinic itself. Certain interactions which are the same in adults is the same in children. Just wanted to highlight this one about DTG interacting with all these multivitamins and iron and calcium supplements. So most children are on these. So we need to fix the timing of the iron supplement, the DTG, the ART drugs. So just a summary. First, we'll confirm HIV infection has to be confirmed by a virological study or a serological test. We treat and stabilize all acute conditions and opportunistic infections. We do a baseline CD4 testing and other lab investigations. This weight and age of the child is only for more than 10 years. Otherwise, weight less than 20 kgs. We start on abacavir lamivudine plus DTG-10 as per the weight band. The dose is calculated. If the weight is between 20 to 30 kgs, we give abacavir lamivudine fixed combination plus DTG 50 milligram once a day. And if the child is more than 10 years, we look at the body weight. If the child's body weight is less than 30 kgs, then the child will go back to this ART regimen and it would be ALD. But if the child's weight is more than 30 kgs and does the next question to be asked is there any known renal disease? If there's a known renal disease, then this child should be evaluated by a pediatrician or referred to a SASIP and a PCOE to assess that ALD has to be given, but how this ALD has to be given, what is the precautions to be taken, what monitoring to be done. And if there is no renal disease and the weight of the child is more than 30 kgs and age is more than 10 years, then we would be giving TLD like we give adults. So this is the important flow chart, which you may take it as a printout and put it up in the medical officers can put it up in their uh, rooms, examination rooms. So the dosage of the ARV drugs are based on body weight. And as I told you, it's an annexure to which can be taken. So let's do a prescription writing. I would like you all to please participate in the prescription writing. I'll wait for half a minute for each of these questions. So child is 6 years of age, weight is 13 kgs. HB is 8 grams, CD4 is 50. What prescription of the ART when you are going to be writing in the green book, what would you write for this child? Let's have some answers on the chat box. Yes, ALD, but what D? You have to be very specific and I want doses. Prescription means with dosage. That's why this dosage chart is kept on this side. So I agree it is AL 6030 plus DTG 10. Very good. But what would be the dosage of AL 6030 and what is the dosage of DTG 10? So you can use this chart to tell us. I'll wait for a few more seconds. I would like you all to make a full prescription. So I'll give you the answer of the first one to understand what is a prescription is, how you will write it in your green, in the child's green book. Very good. Iron needs to be given to this child. Yes. Okay. Very good. I'm very happy with all the answers which have come. So I'll just tell you the answer. So AL per DTG 10 is the ART and the dosage, the prescription is AL 60/30, 2 tablets twice a day and DTG 10 milligram, 2 tablets once a day and hematinic syrup. It can be whatever is available in your hospital and the timing of these medicines should be fixed. Will this child require CPT? No, this child doesn't need CPT. Why? Because one, that the child is more than 5 years of age and the CD4 is 500. So next, I would like you to write the prescription for the next child, 7 years old, weight 19 kgs. HB is 9 grams, CD4 is 300 cells. What would you give this child? Prescription 60/31. Any more answers? Just a few more seconds if somebody else can answer. Thank you. That was right. It is AL 60/30, 2.5 tablets twice a day, plus DTG 10 milligrams, 2.5 tablet once a day. Forgot about cotrimoxazole because the CD4 is 300. So please do remember to write the full prescription when you're writing any prescription in the green book, it should include all the drugs which are to be prescribed. So yes, because the child has got a CD4 less than 350, this child needs to be put on cotrimoxazole single strength, 1 tablet once a day. And of course, iron once a day. The timing of the drug should be monitored. Uh, yes, CPT. I'm very happy. So CPT should always be remembered. Next scenario, please. Give a prescription, 3-year-old child, weight 9 kgs, HP is not available, CD4 is 400, there are no OIs. What prescription would you write for this child living with HIV? The drug dosage chart is here. I would like you to write the whole prescription. Let's have some answers. Ma'am, we don't have DTG 5 milligram. We have DTG 10 milligrams. The child has no OI. So there is no need of waiting for opportunistic infection. We are going to be starting on ART. Any more answers? I'll wait for 10 seconds. Okay. Again, CPT is forgotten. CPT has to be given. You've written the right dose of the ART drugs, but CPT needs to be given. And what CPT will you give? And what is the dose of CPT? Yes, 5 ml once a day. Good. Thank you. So 60-30 AL, 1.5 tablets twice a day, DGG 10, 1.5 tablet once a day, and syrup cotrimoxazole 5 ml once a day. And please evaluate the HP to find out whether the child is anemic or not. So the last prescription is for a 4.5-month-old infant diagnosed HIV infected by 2 DBS for TNA HIV1 positive. Weight is 4 kgs. There are no OIs. What will be the prescription from your side? Let's have some answers. 4.5-month-old infant diagnosed with HIV, 4 kgs, no OIs. Some answers. I'm audible, Shweta?
Yes, ma'am.
Okay. I thought maybe I lost my connection.
No.
Okay. What about CPT, sir? CPT? Yes. Any more answers? So a prescription here would be AL 60-30, 1 tablet twice a day, DTG 10 milligram, half a tablet once a day. For DTG, it's half a tablet when if you see this DTG 10 milligram in the weight band of 3 to 5.9, that is for 4 kgs, it's half a tablet once a day. And syrup cotrimoxazole 2.5 ml once a day. Thank you. So let's go to case scenario 2. Any questions regarding this? Before I shift, any questions? There was one question about CPT, right? You said about allergy to CPT. So dapsone is given if there's a reaction to CPT. But if it's a, remember dapsone is also a sulfur, kind of a sulfur drug. So if it's a life-threatening reaction to Septran or cotrimoxazole, then we do not give anything. But otherwise, if it's a moderate to severe reaction to Septran, then we can give dapsone to that child. Any questions regarding this prescription writing? Can we go ahead?
Ma'am, there's one in the chat box.
Huh?
Can we desensitization?
Yes. So desensitization would require a a tertiary hospital where the child would need hospitalization under a pediatrician and a skin dermatologist where they will give sensitization. So yes, certain children have been given sensitization to Septran and sulfur. It depends on what is the decision by the pediatrician. So any child who has developed a severe reaction or a life-threatening reaction to cotrimoxazole needs to be evaluated by a pediatrician. And if the pediatrician feels that this child can be challenged, can be given dapsone, the child can be given dapsone. If the child needs to be desensitized for Septran, so it would be a decision at a tertiary level where the child would need to be admitted for desensitization. Any more questions? I can proceed. What
Yes,
is
ma'am.
the? Okay, thank you. So our next case scenario 2. So a 3-year-old child presented with altered sensorium since last 2 days and cough and fever since 1 month. History of TB is there, where the father has recently been diagnosed with pulmonary TB, and this child was Master B was admitted and diagnosed to have TB meningitis. The child was started on anti-TB treatment 14 days ago. Weight is 9 kgs and CD4% is 14%. So what are the questions? Is CPT indicated in this child? Let's have some answers in your chat box. Is CPT indicated? Is CPT indicated? Are there any answers? I'm not able to see any answers.
And the responses is yes in the chat box.
Yes. Okay.
Yeah.
Okay. I haven't been able to see. Okay. Yes. Good. So CPT is available. Should be given. And what is the dose of CPT? 5 ml once a day because the weight is 9 kgs. Okay. What ART? When ART should be started? When should ART be started in a child with TB meningitis? Yes. Okay. So ART should be started after completing 4 weeks of anti-TB treatment because this child has got TB meningitis. Steroid should be given as an adjuvant treatment for TB meningitis. Remember, people have a lot of are very scared. Specialists are very scared to give steroids in children living with HIV. But remember, TB meningitis is one of the indications where steroids need to be given along with the anti-TB treatment. So let's go to the next slide. When should ART be started? So the ART, we need to initiate first the TB treatment, and ART should be initiated within 2 weeks of the TB treatment. Only contraindication is if there are signs of TB meningitis, then ART should be delayed for at least 4 weeks where the meningitis has settled down. The child is able to swallow medicine, has become a little conscious, stabilized, and after 4 weeks, between 4 weeks to 8 weeks, the ART should be initiated. The latest within 8 weeks, the ART should be initiated. So only in TB meningitis do we delay the ART initiation beyond 4 weeks. Otherwise, all other TB like TB lymph node or abdominal TB or pulmonary TB, we need to start TB treatment and with ART to be initiated within 2 weeks of starting TB treatment. This is the latest guideline. And of course, CPT has to be given to all children who have tuberculosis because TB is stage 3 and the extrapulmonary TB is stage 4. So now the child, what ART regimen and what dose will you prescribe for this patient? So now the child is completed 4 weeks of anti-TB treatment. The child is stable, and now we need to prescribe and the ART for this child. So what ART regimen and what dose should be prescribed? DTG 10, the child is 3 years. How many tablets? Can somebody say? The weight is 9 kgs.
Ma'am,
Thank
should
you.
I
Thank you
read
for
the
the answers.
responses?
Yeah, I saw the
Yeah.
responses. So thank you so much for responding and being an interactive audience. So the answer is AL plus DTG, 10 milligrams, and an additional dose of DTG after 12 hours. So basically, in TB, we need to make the DTG 12 hourly. And here it will be DTG 10 because the weight is 9 kgs. So abacavir, lamivudine, 60/30 would FTC would be 1.5 tablet twice a day with DTG 10 milligram, 1.5 tablet twice a day. Along with this, we would be giving Septran 5, cotrimoxazole syrup 5 ml once a day. So just to revise, what are going to be the ART regimen in a child with co-infected with TB? So if the weight is less than 20 kgs, it will be AL plus DTG, where DTG will be given twice daily as per weight band. And if the weight is between 20 to 30 kgs, DTG 50 milligram, one tablet will be given twice a day, while weight above 30 kgs and age above 10 years, the regimen would be TLD plus T, ALD plus T, and AL DTG 10 plus DTG 10, where DTG 10 is given twice a day. Now, remember that the DTG dose will remain twice a day for 2 weeks after the last dose of rifampicin, because the interaction is with rifampicin. So the rifampicin effect of hypochromal the stimulation of the hepatic microsomes are going to continue for 2 weeks after stopping ATT. So we'll continue this DTG additional dose of DTG given during this ART regimen when the child is infected with TB for 2 weeks after stopping the TB treatment. But on the other hand, if the child has drug resistant TB, where the child will be put on a non-rifampicin based ATT, we do not need to give an additional dose of DTG in that case. So just a DTG dosing. So if the weight is 3 to 5.9 kgs, DTG would be given half tablet twice a day. That is in drug sensitive TB. If the weight is 6 to 9.9, it would be 1.5 tablet twice a day. If the weight is 10 to 14.9 kgs, it will be 2 tablets of DTG 10 milligram twice a day. If the weight is 15 to 19.9 kgs, 2.5 tablets twice a day of DTG 10. Beyond 20 kgs, 20 and more than 20 kgs, one tablet of DTG 50 milligram film coated would be given twice a day in drug sensitive TB. This is just to explain to you that after 20 kgs, it would become DTG 50 milligram film coated twice a day. Okay, and remember, there is no need to change the dosage of DTG in drug resistant TB. So, any questions about TB before I go ahead? Any questions are there about TB, HIV co-infection in children and its prescription?
Ma'am, we don't have questions in the chat
Okay, so
box. Is it okay if we give mic access at the end for
yeah,
questions?
okay, I'll go ahead. So the next is Master C is 8 years old and weight is 20 kgs. CD4 is 386. HP is 12.6. All the other investigations are normal. Will CPT be indicated in this child? No, CPT is not indicated in this child. Okay, because the child is asymptomatic, clinical stage 1, CD4 is more than 350, and age is more than 5 years. So whenever you're starting ART in any child, the first question you need to ask is CPT is indicated or not. So when you're writing the prescription for a child living with HIV, the first question would be, is CPT indicated or not? Second is that what is the ART regimen? And then you put the dose of the ART regimen. Okay, then what is the second question is prescribe the ART dose. So let's hear. Weight, age is 8 years, weight is 24 kgs. Excellent. Very happy to see the answers. So Answer is ALD. And it's abacavir, lamivudine, 3 tablets in the morning, 3 tablets in the evening with DTG 50 milligram once a day. Very good. Thank you so much for the interaction. The last case scenario is Miss D, who's 14 years old girl or adolescent, is asymptomatic, clinical stage 1, CD4 is 458, weight is 38 kgs, renal function is within normal limits. So first question, is CPT indicated in D? No. Yes, agreed. So CPT is not indicated, clinical stage 1, CD4. So indications of CPT are, is there clinical stage 3 or 4? No, then it's not indicated. The second indication of CPT is CD4 less than 350. And the third is if the child is less than 5 years. So when you're asking about is CPT indicated, ask yourself 3 questions. One is the child less than 5 years? Then yes, CPT. Is the CD4 less than 350? Yes. And the last is there clinical stage 3 or 4? Then yes. So these are the 3 questions when you ask about CPT indicated or not. And the second question is prescribe the ART regimen. It will be TLD, 1 tablet of TLD once a day at a fixed time. Thank you so much for the interaction. So now just let us do some FAQs. So there was one FAQ, a lot of questions were asked because some they were, I think DTG 50 milligram had fallen short in some state, and there was a question that can we give DTG 30? So remember that the question is, can we give DTG 10 milligram, 3 tablets for children more than 21 kgs to 29 kgs? So this is what we want to understand. So first thing is that disposable tablets are not the same bio equivalent with film coated DTG 50 milligrams. What does this sentence means? It means that the drug levels of DTG 30 milligrams are not the same because it's bioavailability. It's a disposable tablet. It gives a higher thing, which is equal to 1 film coated 50 milligram DTG. So you cannot say that we replace film coated 50 milligram DTG with 5 tablets of 10 milligram DTG. It will not be bioavailable. 30 milligrams of dispersible DTG is equal to the blood levels of DTG, which are achieved by 1 film coated 50 milligram DTG. So the guideline says that we use 10 milligram DTG dispersible tablets for all children up to 19.9 kgs. DTG 50 milligram film coated tablets are used for children more than 20 kgs. Now, if the parents say that my child now cannot swallow a film coated tablet, then what can you do? So the 50 milligram tablets are scored. So it can be split into half and they can help. You can teach the child how to swallow because 20 kgs is usually around 5 years where we teach children after 5 years of age to start swallowing pills. Now, if they find that the DG 50 milligram, though is not big, but for a child who's first time swallowing, you can break it into half, split it into half because it's a scored tablet and teach them how to swallow it. Even then, if they are not ready to swallow it, then you can crush it and you can give it with some semi-solid food or liquid and should be immediately consumed. You should not wait for it to be eaten. And if there's a problem where they just refuse to do it, then instead of 50 milligrams of film coated tablet, you can give 3 tablets of DTG 10 milligrams. So the end statement which you should take home message is that 3 tablets of dispersible DTG 10 milligrams is equal to 1 film coated 50 milligram DTG. Please remember, so if there's any shortage of vice versa and you want to use the pediatric tablets instead of the adult tablets, then just remember this thing. It is not 50 is equal to 50, it's 30 milligrams of dispersible DTG is equal to 1 film coated 50 milligram DTG. The second question which frequently parents ask is, can DTG be taken with food and milk? We usually say that DTG dispersible tablets can be taken without meals. You can just take it with plain water. But if the child is not willing to take, because it's a very beautiful strawberry flavored tablet, it can be taken with milk and food. Ideally should be dispersed in water. But if the child is not ready to take it with water, you can give it with milk and food. But remember that it's a dispersible tablet. That means it has to, it becomes a solution in water. So in if you're giving it with milk and food, it should dissolve first and it should be immediately consumed. It should not be dissolved and kept in the fridge and given after some time. So it should be immediately consumed. So that is the importance about educational videos which are available. These are NACO videos which are available, and it's about how to dissolve the DTG10. Shweta, would you please show the video? I'll
Yes,
just
ma'am.
unshare my,
Yes, ma'am.
I'll just stop sharing and now you can show the video, please.
Yes, give me 2 seconds, ma'am.
Now let's talk about how to actually give the tablet dolutegravir 10 mg. The first step is hand washing. Make sure your hands are properly washed before you give the medicine. While it is best to give the medicine in clean water, it can also be given with milk or some other food. Use a clean spoon and glass or katori to dissolve the tablets. To dissolve half or up to 1.5 tablets, 1 teaspoon or 5 milliliter water should be used. For 2 tablets and 2.5 tablets, 2 teaspoons or 10 milliliter of water should be taken in a small glass or katori. After adding the correct number of DTG 10 mg tablets, make sure that the tablets are fully mixed in the water. If you see any bits or lumps, stir with a spoon. Do not use more water as the child might not be able to drink the whole amount and will not get the correct dose of medicine. Now the medicine is ready to be given to the child. Ensure that the child takes the complete amount of solution. If there's some medicine left in the glass, add 1 teaspoon more of water, stir and make the child drink it fully. The medicine prepared needs to be taken within 30 minutes of mixing or dissolving the tablet. The DTG 10 mg tablets are flavored and are usually taken by children without any fuss. However, if your child does not like the taste of the pill and water, the medicine can be given with juice, curd, milk, etc. It's very important to give the ART medicine daily at a fixed time as per the child's routine.
Does the law of attraction really work? When I started my journey,
Over to you, ma'am.
Yeah, I'm just saying. So I would like to inform that these are present, these videos made by through NACO are present on these links, YouTube videos. There's Hindi and English. And I think we all should share it with all your caregivers. The counselors also should have it if there's some difficulty with the parent who's not confident in how to give the ART drugs. Secondly, you can also play these in whenever you have some get-togethers in your ART center. So the second slide is this job aid. So you can give a printout of this where they can understand. So it's in English and Hindi. What are the dosage which has to be given, how to prepare it, what are the benefits. It's a beautiful job aid which is available. You can scan this in English and Hindi. It's a QR code. You can take this and you can actually give this to the caregiver's mobile. So they can always have it and read it for it. If they are getting a little, they are not having so much confidence in doing it, they can have these as reminders in their mobiles. So it's available as English and Hindi. These are very good job aids which should be actually given to uh, all the children. So now I can do the post test before doing the questions, or any
Yes,
questions. Let's
yeah.
ask. Any questions, please?
Kiran sir, we can give mic access to everyone.
Given.
Thank you. Any questions from the participants? Please feel free to unmute or you can put your questions in the chat box. Any questions?
AL 60/30 is bitter, agreed, but the DTG is not bitter. And we can give AL 60/30 plus DTG all mixed together and give it. Okay. Both the tablets can be dispersed together.
Ma'am, we'll go ahead with the post test and
Okay.
keep the forum open for question answers as well.
Okay. So just the first question was ART regimen should be advised for a child who's 5 years and 22 kgs. So as I told you, it's not the years, it's the weight. A child more than 20 kgs would be given AL plus DTG 30. That is, answer is D. The second question was 7-year-old child weight 18 kgs and CD4 450. Now the weight is less than 20 kgs. So this child's third drug would be DTG 10. So the correct option would be AL plus DTG 10. So here is the thing. It is not the age except beyond 10 years where we do TLD in less than, it's less than 20 kgs or more than 20 kgs. Less than 20 kgs would be DTG 10. More than 20 kgs would be DTG 50. And a 2-year-old child weight 9 kgs with TB lymphadenitis would be given AL DTG 10 plus an additional dose of DTG 10 after 12 hours. So DTG 10 would become twice a day. The reason why we written DTG 10 milligrams again is to remind that this is an additional dose of DTG which will continue for 2 weeks after the TB treatment is stopped. And after these 2 weeks of additional DTG after stopping TB treatment, this additional DTG will also stop. And so in after the 6 months of TB treatment plus 2 weeks of additional DTG, the child will go back to AL plus DTG 10. A regimen, ART regimen for 12 years and 32 kgs would be TLD. Thank you. Any questions?
Any questions? Participants can please unmute or they can put their questions in the chat box. Ma'am, I don't think there are any questions. Thank you so much for facilitating this important session.
Thank you, Shweta, and thank you to all the participants for a patient listening and being interactive and putting answers in the chat box. I'm very grateful for your patient listening. Can I stop? I'll
Yes,
stop
ma'am. Yes,
sharing. If there are, we can wait for another 1 minute if anyone has any questions, and then
sure,
you
ma'am.
can take a call what you want to do.
Sure, ma'am.
And feedback form is pending.
Yeah. Sorry. I accidentally deleted it. I'm really sorry. Can you relaunch? Is there a chance? I
Nobody
ended
has
the
done
poll.
it, so you can relaunch it because nobody has entered in it as yet.
Yeah, thank you so much. Requesting all the participants to please fill in the feedback form for this session. There are 5 questions in all. Scroll through the questions and please click on the answer of your choice. Requesting all the participants to attempt the feedback poll. We have 92 participants now, so almost 90. Another 2 minutes for the feedback poll. Ending the feedback poll now. Thank you, everyone. Thank you for joining in and patient listening. We'll conclude the session now. Thank you, ma'am.
Thank you so much. I'll log out.